My presentation is on frozen shoulder/shoulder impingement arthroscopy. So the relevant anatomy, there's the glenohumeral joint made up of the humerus and the glenoid, and you have the glenoid labrum that sits inside there. The acromioclavicular joint, which is made up of the acromion and the clavicle. And then the ligaments, you have the coracoacromial, coracoclavicular, and acromioclavicular. And then the rotator cuff muscles that stabilize the joint, so the infraspinatus, supraspinatus, teres minor, and subscapularis. Background for my patient, he was a Caucasian 45-year-old male in insurance administration, but plays in an adult recreational baseball league. Has a previous history of a rotator cuff strain and tear, but no previous history of any surgeries to the shoulder. It is also the left shoulder. Signs and symptoms of he was presenting were pain and tightness during overhead motions, weakness, and a constant ache. And then conservative treatment failed with rest and physical therapy. Differential diagnoses were shoulder impingement, subacromial bursitis, rotator cuff tears, and biceps tendonitis. And it was determined that he had shoulder impingement with adhesive capsulitis, which is also known as frozen shoulder. The surgery date was November 19th, 2019 with Dr. Palmer at DOS, and it lasted about 40 minutes. The surgery technique, so they were placed under general anesthesia in the lateral decubitus position with their arms suspended and they're laying sideline. Then they took a pen and identified landmarks for them to open the incisions, took a scalpel, opened them up wider, and then placed the portals through and probes. An arthroscope and shaver were inserted to remove the capsulitis around the labrum, the rotator cuff, and anything around the humeral head. There was some scar tissue buildup around the rotator cuff and the labrum, and an increased amount of buildup around the acromion and on the superior posterior side of the rotator cuff, where he likely had some of those strains or tendon because the tendons were degenerating. And after he cleaned everything out, he moved the humeral head around to make sure there was no limited range of motion. Post-operative care, wound care is important, keeping the dressing on for 24 hours and then keeping it dry for 48. It can be exposed in the shower after 3 days, but making sure not to scrub it. Maintaining clean bandages and avoid soaking until the wound has healed completely, and it may be more comfortable to sleep in a recliner with the arm supported. General rehabilitation, so during week 1, soft tissue to surrounding structures, light pendulums, assisted range of motion, maintaining cardio through walking or through a stationary bike, and then working on grip wrist and later elbow strengthening. Week 2 through 4, isometrics can be started and active range of motion as well. Isotonics can be progressed to as tolerated. Weeks 4 through 6, an increased rotator cuff strengthening using TheraBands and weight-bearing exercises. Weeks 6 through 8, an advanced strengthening and stabilization protocol, and then beginning a throwing progression. And then over 8 weeks out, progressing to plyometrics, and then to return to sport if you want to continue baseball, sport-specific exercises. Results and deviations from expected. Overall, the surgery went pretty smoothly. There was that buildup at scar tissue, but most likely due to the previous history. Not a lot of osteoarthritis around the acromion was present either, which can be in often cases. And then also in often cases, they can find previous injuries or other injuries that were present that maybe weren't identified before, such as a infraspinatus tear during the scope.